So we know that randomized clinical trials are the gold standard to acquire new clinical evidence. Registries, on the other hand, can help us to get better insight on how this new clinical evidence is adopted in clinical practice. And there are a number of registries, and I just want to name the one by the European Society of Cardiology, the atrial fibrillation registry, which I think sheds really important insight in how new technologies is adopted. So number one, we learn how other countries adopt certain technologies for AFib ablation. Are they underutilized, which may lead to initiatives to address the adoption of this technology. We understand what the complications rates are. Oftentimes complication rates are maybe a little higher in registries just because the centers that participate are maybe less experienced than in clinical trials. So that is, I think, an important safety issue that needs to be addressed if new complications arise that have not been reported before. Another important point is how the outcome is after the ablation. Is it as good as is seen in clinical trials? Oftentimes, maybe the outcome is less favorable. And I think that's where registry data is really important. I do think also, besides registries conducted by societies like the European Society of Cardiology or ERA, post-market studies by companies are getting more and more important just to really get a better idea of how the technology does outside of a clinical trial setting. Well, first off, I want to state that women are typically underrepresented in any of the trials looking at evidence for ICD or CRT implantation. I do think that for the secondary prevention in patients with ischemic cardiomyopathy, ICDs really have equal benefit for women and men. For the primary prevention, I think the data might be less clear. I think in the clinical trials it has been shown that women typically have derived the same benefit. However, there are certain meta-analyses that were published that showed that women might have actually a lesser benefit. And why could that be? Well, for one, we know that women have a lower mortality in the setting of ischemic cardiomyopathy. They have less appropriate ICD shocks, and they have fewer episodes of VT and VF. And we know that women, after myocardial infarction, have less scar than men. And they also have less appropriate or less shockable rhythms when they present with sudden cardiac death, such as asystole or pulseless electrical activity. So these might be reasons why women just derive lesser benefit than men. Now for CRT, same thing. We know that women are largely underrepresented in these trials. Less than 30% are women. However, for CRT, it seems that women derive a greater benefit. So they have a lower mortality after CRT implantation. They have less heart failure. They have greater improvement in left ventricular ejection fraction. And they do have a better improvement in New York Heart Association classification. Now, what could be the reason for this? Well, for one, we know that women derive better benefit for CRT after CRT implantation if they present with a left bundle branch that is less than 150 milliseconds in duration. I think one reason why women benefit more from CRT therapy is that at baseline they have a shorter QRS duration. So if they develop a prolongation in their QRS and left bundle branch block, they derive a relatively greater benefit because they have relatively more dysynchrony than men.